screen. Is my screen visible to all of you?
Yes, sir, it is.
Yes, yes, it is visible.
So we will start. So good morning to everyone in India and a very, very good evening to Mark. Thank you once again for joining us from California. So we start today's proceedings with a pretty tough topic, which is double outlet RV in the fetus. So we will talk about the classification, some terms and diagnosis of this, which is the mainstay, and of course how the anatomic information decides the management. So the learning objectives of this lecture include understanding the classification and surgical anatomy, and this is not very easy, and there are so many variations within DORV. Imaging considerations will be our mainstay of this lecture, how to get the required anatomical information. And here I will talk about the incremental role of 3D STIC imaging, and we have done some original work on this. And finally, we'll talk about the counseling and prognostication. So what is double outlet right ventricle? So in simple English, we can say that this is a heart defect when both the outflow tracts are emerging from the right ventricle. Here, in a more complicated and a little more sophisticated cardiac jargon, we can say that it's a defect where the circumferences of both the outflow tracts are predominantly supported by the morphological right ventricle. It is often associated with anatomical features like bilateral infundibulum or corni. Then the second way is we say there's a more than 50% override. Tetralogy is up to 50%. And finally, what we call the aorta mitral discontinuity. But these are anatomic features and need not necessarily be the defining features. Now, why is it important to understand DORV individually, each case separately? This is because the anatomy often decides the surgical approaches. Sometimes, the DORV can be fixed by a single stage operation with excellent outcomes and need not necessarily have a complicated postnatal course. What are the anatomical features which decide the surgical approaches? These include the location of the ventricular septal defect. The second feature is a very important feature, that is the relationship of the VSD to the outflow tract. And this is a phrase called routability, which I will come to later. The relationship of the outflow tracts to each other and whether the outflow tracts are obstructed or not. And the presence of these features will decide whether the heart is amenable for an anatomic repair, which means a complete correction, or whether only palliative approaches can be offered. Now, yesterday, briefly, we spoke about the anatomy of the ventricular septum, the en-face view. And here we have the ventricular septum as shown from the RV side, and it has different parts like the perimembranous portion, the outlet portion, the inlet portion, and the muscular portion. The perimembranous, as we had this discussions yesterday, also is known as the sub-aortic, and typically it's always sub-aortic. Outlet is a portion which is usually in the outlet septum, typically comes under the PA, and inlet is near the tricuspid valve. So based on the location of VSD, and this is very important for DORV, we have different types of location. The sub-aortic VSD, which is perhaps the most common type, the subpulmonary VSD, which is the second one, and then we have this entity called doubly committed, where there is both subaortic and subpulmonary. These are all situations where the what we call routability is possible, and I'll come to that point. That's a critical point in DORV later. And then there are other locations like the inlet and the remote or muscular, and in these cases, it is not possible to offer anatomical repair. Hence, it is extremely important to really finalize the location of the VSD with precision, because it decides the surgical management. So this is an example of, again, the same thing, the different VSDs, the subaortic, the subpulmonary, and the inlet VSDs. And here in this cartoon, we have shown the great artery relationships also. So in the first tab, we can see that this is a subaortic VSD, which is routable to the aorta. Now, we use the 3D 4D STIC MPR technique. And typically, yesterday, again, there was a request to do this, which we'll do even later as a separate program, how to get these images. Typically in 3D 4D, we take a volume data set, very similar to the MRI data sets which you do. And then you have different planes, like A plane, which is a reference plane, the B plane, which is 90-degree orthogonal to the reference plane, and then the C plane, which is at the coronal level of the AV valve, the coronal plane. For the ventricular septum, we use the B plane, and then we can get the en-face view like this, and a picture can be rendered this way. And yesterday, I showed you how the different locations of the VSD can be actually elucidated. Then we have the spatial relationship of the outflow tracts. And we have different types of outflow relationships. The normally related great arteries is where the aorta is right and posterior, which is less common. And in DORV, the most common is the side-by-side great arteries. We can have an aorta which is right and anterior, often called the D post aorta. We can have a directly andro-posterior relationship like here, or we can have an aorta which is left and anterior. So all permutations and are possible. So this is how complex the whole scenario is. So in DORV, based on the location of the VSD and the outflow tract relationship, we can have different types. As we can see, the most common location of the VSD is the sub-aortic VSD. And the most common great artery relationship is the side-by-side great artery. So about 46% of the DORVs will be having sub-aortic VSD with side-by-side great arteries. 68% have sub-aortic VSD and 22% have subpulmonary VSDs. Now, this is a very, very important slide, and I want your complete attention on this. And this is an important concept to understand before we go to imaging. So if this is DORV, you have the left ventricle over here, and this is the right ventricle over here. You see both the great arteries are coming from the RV. In fact, here the PA is closer to the LV, which means it's probably a TGA type of DORV. And you can actually do surgery in two ways. Suppose if the surgeon puts the patch like this way, what will happen? Both the great arteries will remain committed to the RV, and that's not a good way to operate a heart. Rather, you would want the surgeon to put the patch this way. Thereby, he commits one artery to either ventricle. In this case, by doing this VSD closure, the PA is committed to the LV and the aorta remains committed to the RV. And this can be repaired by using an arterial switch operation, resulting in a complete repair. So the most important thing to remember is that the plane of space that needs to be closed as a VSD is not the interventricular communication, but rather it is a space inside the right ventricle. So this is a whole concept of routing the VSD in DORV. And this is a very important concept to understand when we talk about management of DORV. So there are two types of VSDs, the routable VSDs, which are typically the subaortic and the subpulmonary VSDs, and the non-routable VSDs are the inlet VSDs and the muscular VSDs. Now, the view to get this is again, we go to the 3D 4D STIC technique, the en-face view of the base of the heart. That is the plane which we use is the C plane here. In the C plane, we get this picture, and where we see the relationship of the various valves, and this is a normal relationship here. The aortic valve is between the tricuspid and mitral, and there is an aortomitral continuity. And this is a picture which yesterday I showed. The aorta and the mitral valve are close to each other. Okay, so this is regarding so much about the basics in DORV. Now let us move on to the specific discussions. And we are going to mostly discuss two types. And if time permits, we will go on. I'll quickly show some other variants. So the two important types of DORV with subaortic VSD, that is a TOF type DORV, and the DORV with subpulmonary VSD with transverse outflows, which is a TGA like DORV. So first, let's talk about the subaortic VSD. So this is the most common type. It can have pulmonic stenosis, then it becomes exactly very similar to tetralogy of Fellow. So let us see some clips. So this is first four-chamber view. Clearly, the VSD is made out. And with a little bit of a cranial angulation, we can see that the VSD, and we can also perhaps see a outflow emerging. So until this point, we can say, oh, this is possibly a malaligned VSD with overriding of the outflow tract. That's where the VSD is. Moving along, now we can see very clearly how the outflows are related. So here we see the LV to the aorta pathway very much clearly. And here again, that's shown well. So this is the LV and this is the RV. And you can see that the aorta is significantly overriding. And most of the aorta seems to be coming from the right ventricle. as we can see here as well, the color flow pattern. It's a, as you can, if you compare it with the tetralogy, you can see that the angulation and the degree of override is clearly more in this case. And by the arrows, I have actually shown the pathway from the LV to the aorta. So again, the same thing. So you can see the LV to the aorta pathway. The aorta is completely arising from the right ventricle. And with the cranial tilt, you can see here the pulmonary artery is also arising from the right ventricle. And the pulmonary artery is smaller compared to the aorta. So with modern technology, there are machines where you can actually do a live biplane imaging. And this is an example of that kind of an imaging. We are seeing the LVOT and the RVOT together in the same plane, where we have actually used the imaging plane centered around the LVOT. And at the 90-degree angles, the machine generates the B-plane image automatically. So here we can see the LV to the aorta pathway, and we can also see the right ventricle to the PA. In fact, if you look closely, you can see that there's a lot of muscle around the subpulmonary area here, causing severe pulmonary stenosis. So this is an example of what we call the TOF-like DORV. And in the same patient, in the 3-vessel view, we found out that the PA was smaller, indicating pulmonary stenosis. Now, how do you differentiate between TOF and DORV? One way is to look at the degree of the aortic override. So this is tetralogy, where you have about 50% aortic override. And then you have here the DORV. You look at this, aorta is predominantly coming from the RV, more than 50% override. So in this, the latter scenario, we can very clearly see that the circumference of both the outflow tracts, semilunar valves, are completely committed to the right ventricle. So this is one simple way. The other way is to look at the aortomitral discontinuity, which you can see here. So this is the aortic valve over here, and this is a mitral valve here. And if you look at this white bar over here, that is a sub-aortic corner separating the mitral and the aortic valve. So this is another way by which pediatric cardiologists define DORV. Now I'm going on to some 3D reconstructed pictures to show the LV to the aorta pathway. We can very, very clearly imagine how this is going. The arrows are showing the aorta is totally from the right ventricle, but we can see the clear path from the LV to the aorta. And by color flow, we can see that's the way the LV to the aorta, this channel will be created. So now I'm going to show both the outflow tracts in a rendered view. Here is the right ventricle over here. The aorta is large vessel here, completely coming from the RV. The PA also is coming from the RV. And here it's something like a almost side-by-side relationship. Maybe PA is a bit anterior. You can see both the outflow tracts are coming off from the RV. So the LV to aorta has to be routed this way, and then the RVOT will be reconstructed in this manner. So this seems to be a TOF-like DORV where a surgical repair is easily possible. So this is actually the surgical pathway reconstruction. So this will make this very clear to you. And everything is annotated for easy understanding. You can see that the aorta is completely arising from the RV here. And the surgeon will have to close the VSD in this manner, so that he commits the LV to the aorta this way. And that's how it is. That's how the picture will come. The LV to the aorta is committed this way. And then you have the RVOT coming here. And simply you see at the bottom of the PA, there is a narrowing. So that's the pulmonary stenosis. And then they will put a patch to repair the RVOT. So a total correction is possible with a good outcomes. Now, this is how we look at the VSD in the on-fast reconstructed view. So here we have the RV and the tricuspid valve. This is the LV and the mitral valve. And the green arrow is showing the route from the LV to the aorta. So it's a routable kind of a VSD. So the LV to aorta routing is possible. And then here we have the on-fast view of the ventricular septum here, and that is reconstructed here. You see the VSD is where the star is. So it's a sub-aortic VSD. And you can clearly imagine that this is the way the surgeon will be connecting the LV. LV is actually behind. You can't see the LV because it's on the other side. And the surgeon's patch will go through the VSD into the aorta. And then here we see the RVOT, and that will be reconstructed by a simple RVOT resection. So with this kind of imaging, it is quite clearly possible to tell the surgeon that, look, this is a DORV which is totally correctable with a single surgery. And the parents also will be very happy to listen to such news, because that will encourage them towards seeking postnatal care. Now let us see DORV with subpulmonary VSD, which is also called a transposition type of DORV. So this is really a situation where we have found 3D, 4D STIC reconstruction particularly useful. Now, the four-chamber view looks absolutely innocuous and normal, but towards sweeping, as this is the view which Mark showed, his favorite view, 2.0 view. And here we can see both the outflows are clearly emerging from the right ventricle. You can see the VSD as well. And when I put color flow, you can see the VSD, the red flow across the VSD. In DORV, the VSD will shunt left to right. That's because it's an obligatory left to right shunt. There is no other way for the LV blood to exit to the heart, so it has to go across the VSD to the RV, and that's what is shown there. And we can very clearly see that both the outflows are coming off from the right ventricle. And here is a rendered picture of the outflow tracts. And if you look carefully, this is anterior and this is posterior. And you can see that the first outflow is bifurcating here. So that's the PA, and the more anterior outflow is the aorta. And that's very clearly made out from this rendered picture. Moving on further towards the aortic arch, we can see that the three-vessel tracheal view is nicely forming with no obstruction on either side, and the aortic arch is completely unobstructed. So this is really a classical type of DORV with a TGA type of DORV, and that's a subpulmonary VSD. So yesterday, Mark showed one image of tomographic ultrasound imaging where you can get all the planes together. This is what I call the CT-like image. And in the most caudal plane, we can see the VSD. And then in the middle panel, you can see both the outflows are arising from the right ventricle. And on the topmost panel, you can see the two outflows converging together to form the arch. And that's a completely normal three-vessel tracheal view. So we can say that this is a DORV with the subpulmonary VSD with the transposed outflow tracts. Now here, what I have done is I have rendered, yesterday I showed the surface rendering of the heart. And here you see, to compare the normal heart with this, you see the classical picture which the surgeon will see. And this is the DORV with the TGA type. RV comes here, aorta is bang on arising from the RV. PA is closer to the LV. And so it's a TGA relationship. And when you slice this open, you can see this picture where you can actually see this is the left ventricle over here, the right ventricle here. Aorta is totally from the RV. The PA is more closer to the LV, and it's a TGA type of relationship. So here, this is the C plane imaging, the LV and the mitral valve, and this is the VSD. And we can see that it is closer to the LV, and it is a subpulmonary in location. Here we cannot route this LV to the aorta because aorta is far away, but we can route the LV to the PA. So that is what is shown here. The routing is possible to PA. And then let us imagine how the surgery can be performed. So this is the original heart. The aorta is completely from the RV and the PA is predominantly from the LV. So the first step to do is to, got stuck. Yes. Okay, sorry. Okay, imagine. Okay, fine. So sorry, I just got stuck. So here, let us imagine the surgical pathway. So this is the original heart. So we see the aorta is completely from the RV and the PA is more closer to the LV. So the first step to do is to close the VSD this way. And thus you convert this into a simple TGA. And then you do a switch and complete the repair. So here it is possible to route the LV to the PA and complete an arterial switch, and thus a single stage repair is possible here. So a heart which looked like this can be converted into a completely normal heart, and this entire thing can be predicted using the imaging techniques which I showed. Now I'll show you a couple of more complex examples. This is a normal looking four-chamber view. Here you see overriding vessel with the VSD, and the overriding vessels appears to be bifurcating. The aorta is not fully seen. Now you can see the parallel outflow tracts. There's a VSD with a large PA overriding the VSD. The aorta appears much smaller here. And you can see this much smaller aorta. And that's it. That's a picture which nicely depicts the the relationship of the great arteries. The PA is a huge vessel compared to a smallish aorta. The aorta is about, Z score is about minus 1.5. And moving towards the aortic arch, we can see that the aortic arch is overall significantly hypoplastic. Overall transverse arch is hypoplastic. And with rendering, or the STIC rendering, we can see the overriding PA, the huge vessel, and the aorta is small. Yesterday, Mark showed in TGA the importance of posterior deviation of the cornal septum, posterior malalignment. Here, rather, we are having an anterior malalignment, which means that the subaortic area is a little bit narrow. So in this case, whenever we have to look further and look at the aortic arch, so here we can again see in a movie how small the aorta is compared to the PA. And going further towards the aortic arch, we can see that there is a significant narrowing of the aortic isthmus. So this is what we call a tossing Bing type of anomaly. DORV with a subpulmonary VSD, transposition, transposed great arteries with possibility of coarctation. So how do you fix this? And this also can be fixed by a single stage repair where you route the LV to the PA and do an arterial switch like the previous illustration animations I showed. And then in addition to the arterial switch and VSD closure, you also repair the aortic arch. All of this may sound very sort of high for many people, but in fact, there are many pediatric cardiac surgeons in India who can actually do this very well, including several in Mumbai. So these are all things which are routinely done in our daily life, and these patients have pretty decent outcomes. Some of these kind of patients may have residual obstructions in later life, like pulmonary stenosis, but most of them can be offered reasonably good solutions also. So this is one more DORV. These are all really more complex types of DORVs here. You can see the LV to the aorta pathway as shown before. And again, you see that the aorta is predominantly coming from the right ventricle here. And this is the LV to the aorta pathway. So there is no question about the routability, it is routable. And now we see the pulmonary, and here we see what we call the posterior deviation of the cornal septum. So this is seen, there is a significant protrusion of the cornal septum into the pulmonary artery here. So the previous case I showed anti-deviation of the cornal septum causing aortic obstruction. Here the aorta is clean, but there is significant posterior deviation of the cornal septum, which is shown here as well. The PA is smaller than the aorta. And in this 3VT view, you can very clearly see that the PA is much smaller compared to the aorta. And in this reconstructed picture, we can actually make this out very well. The aorta is clearly anterior, PA is posterior, and PA is smaller. So what do we do in this situation? So it's an example of a DORV with subpulmonary VSD and TGA and pulmonary stenosis. And this is very nicely rendered here. You can see that there is a significant narrowing of the subpulmonary area, while the aorta is huge here. So this is the moving picture. So unfortunately, because of the presence of pulmonary stenosis, we cannot do an arterial switch operation here, because the pulmonary stenosis will become aortic stenosis after surgery. So in this case, often these patients will need a more complex form of repair. So what can be offered here? In this case, what the surgeon will do is they will try to route the LV to the aorta, and then the surgery will be completed by putting an external graft called the conduit from the right ventricle to the pulmonary artery. So this is a kind of a surgery which often may need more than one stage. If the baby is significantly cyanosed at birth, they may not do this in the newborn period, but they may want to do this a little later. So typically, this kind of DORVs may require more than one operation. Now, let me just show a couple of examples of complex DORVs. We still have 5 more minutes. So in this is a situation where the VSD is in a more difficult location like inlet or remote, often associated with situations where the AV valves straddle the VSDs, which means connections inside the VSD. In simple terms, all this makes the routing of the VSD to one of the outflows not possible. So here is a classical example. You see here, there's a VSD, and you see the valve connections here, over here. And because of this, that's the star where I have shown the VSD. You see protruding valve tissue into the VSD. So because of this, it is not possible to route the LV to either of the outflows. So that is one example of what we call a non-routable type of VSD. So here a biventricular repair or anatomical repair is not possible. So this is another example. Obviously, this is never a case for an anatomical correction, but look at the left ventricle. It is quite small, and there are multiple VSDs also. And this is a DORV where both the outflows are coming from the RV. So this is actually an example of a DORV with a hypoplastic LV. And yesterday we discussed about this mitral atresia thing. Now here the mitral valve is quite small, almost atretic. So mitral atresia is not something which is unique to HLHS. Here somebody looking at this 4-chamber view will call it as hypoplastic left heart syndrome. So it is not hypoplastic left heart syndrome because only the features which are there are the mitral valve small and the small LV. But when we look at the outflows, you see that there is absolutely no aortic atresia whatsoever. So there is a double outlet from the right ventricle. So this is the point which we were alluding to yesterday. So obviously this case will only go for a univentricular repair. So this is the final case, how much complex congenital heart disease can get. And look at this here. You can see there is a reverse offsetting. The mitral valve is here, you see the LV is here, the RV is here. And when you look at the pulmonary vein drainage, you can very clearly see that the left atrium is over here. You can see the pulmonary veins draining there. In fact, so beautifully, you can see the appendages here, the finger-like LA appendage and the broad-based RA appendage here. You can see the LA appendage and the LA is connecting to the RV. You can see the pulmonary veins also is draining to this atrium, which is connecting to the RV. So there is atrioventricular discordance. There is a VSD here, and we can see the relationship of the outflow. The RV is completely supporting the aorta. So that is, and the PA is coming over here, which is actually much more closer to the LV. And when you look at the outflow tracks, the 3VT view in color, there is reverse flow into the PA. So what all we have AV discordance, we have a large VSD, we have an aorta completely coming off from the RV, a PA also predominantly committed to the RVs, that is DORV, and then there is a pulmonary atresia. So there is an AV discordance DORV with pulmonary atresia. So even this can be fixed by doing the following maneuver. The surgeon will do an atrial switch, thereby correcting the AV discordance. And then they will route the LV to the aorta. And then they will put an RV to PA conduit. So this is what we call a double switch kind of a procedure, and typically done in stages. But even this we can predict by using imaging techniques, as shown here. So I think I have pretty much covered most forms of DORV, which we can see. And the counseling and prognostication, first up, of course, we have to rule out the genetic and extracardiac anomalies. Then we do the series of images as shown to decide whether an anatomical repair is possible and whether it is a single stage. So these are some of the extracardiac and genetic anomalies which we see. And commonly trisomy 18 needs to be excluded along with 22q deletion. So this is our series which we publish in Ultrasound and Obstetrics and Gynecology. Balaganesh Karmagaraj, who is attending this, is one of the, he's the first author. And here we compared the 3D, 4D with the 2D. In each of these parameters, VSD, location, routability, relationship of outflow tracks, everything 3D, 4D had a superior accuracy. And combining all parameters, we could accurately identify the anatomic features in 86% with 3D, 4D. And mind you, all this was compared with the surgical findings, not even the postnatal echo. And using the 3D, 4D, we could predict that the postnatal surgical pathway accurately in 91% cases compared to 54.5% with 2D. And for single stage correction like arterial switch, the predictive accuracy was 100% with 3D, 4D. So this is really quite a remarkable difference, with 3D, 4D imaging, which we got from this study. So this is the same thing. The overall prediction with 3D, 4D was a 91% and 100% for the single stage repair. So to summarize DORVs, we can have different locations of VSD. All the green ones are routable VSDs, subaortic, doubly committed, and subpulmonary. The great artery relationship could be normal or side-by-side or transposition. And typically with the doubly committed VSD, transposition is more common. You can have pulmonary stenosis, or sometimes you can have even aortic obstruction. So surgery will depend upon the location of VSD, the great artery relationship, and outflow obstruction. You can do even a simple VSD closure, or TOF-like repair, a TGA-like repair, a more complex repair, and in certain situations like a remote VSDs or a straddling valves, we can only do either a very, very complex biventricular repair or only single ventricle repair. Fortunately, the last group is only about 10 to 15 to 20% of DORVs. So in the vast majority, it will be possible to offer anatomical correction. So to summarize, double outlet right ventricle in the fetus is a bit more than both outlets from the RV. This is indeed a complex kind of a heart defect with complex facial anatomy of the VSDs to outflows. And the most important point I would like to make is that a surgical management and counseling is individualized based on anatomy. And when you sit in my chair or Mark's chair, this is the questions which you have to answer. Most forms are amenable to single stage repair. That's the good news. And hence it is important to identify the complex forms needing reoperations or other complex pathways. And this is where I very strongly, I'm convinced now that 3D, 4D STIC has a clear role in understanding these anatomical relationships. So thank you so much. And we can probably take some questions and discussions maybe now or later, depending upon the time. Thank you.
Thank you, sir. Thank you, sir, for that diagnosis.